Thank you, Robbie. Thank you, everyone who is attending today, has attended the last two, and everyone who worked together to put this together so quickly. I mean, we threw these webinars together really within, I think, less than a week. I mean, the team at UNC and NC and Robbie, of course, have just been fantastic trying to get this out because we know this is very relevant to many of you very suddenly. So thank you, everyone who helped make this happen. So as Robbie mentioned, this is the third of a three-part series that I put together, and I kind of tried to build them off of the questions I was getting from first to second, second to third. So please go back and, as he mentioned, look at those again. I tend to pack a lot of information in a short time. So, go back and look at that, see if there's something that you missed or something that you want to review after we get through 2 and 3. And at the end of this, I'll have my contact information. You can feel free to reach out to me after if you have questions. I'm happy to help. So the focus of this presentation specifically is to help you modify what you're doing to synchronous telemental health settings. So synchronous, if you remember, means video and phone. It means real-time back and forth. Asynchronous refers to text, chat, emails, that kind of thing. So we're focusing just on the synchronous, and we're looking at basically 3 areas today. One is how to address the needs of couples and families of those affected by gambling disorder, how to facilitate groups if you're running a group, how to get them online, and how to handle emergencies that may come up during your telemental health sessions, because this does look a little bit different than face-to-face. So what we already know, right, with couples and families, we know roughly about half of helpline callers, both state and on a national level, are actually family members or significant others of the person who's gambling. So we know couples and families, they're hurting too, they have questions too. The research is kind of mixed about treating the couple together versus individually with a focus on gambling. So on one hand, it can help support the behavior change and prevent relapse and prevent those patterns from coming back up by educating the significant other or family member. But when we take it from the perspective of entering couples or entering family counseling with the intent of focusing on the gambling disorder, and the person who's gambling is not ready yet or willing to change the behavior, it actually can hinder progress and create more stress and more difficulty for the family. So just as when you're treating them in your office, looking at doing couple and family, it really, a lot of it's going to depend on the motivation of the person who's gambling. We know problem gambling at any part of the spectrum affects family functioning. So involving the family in treatment has been linked to better outcomes overall for the family and for the gambler, but again, only if it's part of their treatment plan. And problem gambling behavior may come up during counseling, not specifically as the presenting issue. But one of the things we're seeing with our current situation with COVID-19 is that all of these behaviors that maybe were being maintained day-to-day life are suddenly becoming exacerbated, becoming problems. We're hearing a lot of issues come up that they could maintain their drinking, their gambling, whatever before, but now they're under stress, they're at home. We're seeing things get a little bit worse. And I discussed that a little more in depth in the first presentation about the impact of COVID and gambling disorder. But, we're seeing that it might come up. You might be treating a couple or family or an individual for something else, and it might, come up in the course of how they're coping with stress. Or maybe that they have been in recovery for years and all of a sudden they're going back to it. So we know we have to kind of stay aware of these things because it may not be the presenting issue, but especially now when people are under a significant amount of stress and financial stress, it could be popping up. So the person with gambling disorder may have a lot of anxiety about sharing information to their partner or family about specific behaviors, maybe how much debt they're in, how much they've lost, the types of gambling they're doing. They may have a lot of anxiety about revealing that, as we know. The really interesting, kind of unique feature of telemental health is that they can talk from separate locations. So they can be in 2 different places and you can help them, have this conversation and they don't have that pressure of being face to face. Now, obviously, they would still have to come together later at some point, but that initial blow, so to speak, can be a bit softened through telehealth because they don't have to be in the same room. So if you have someone with significant anxiety, particularly social anxiety, that they have difficulty with conversations anyway, or maybe they're so far into gambling disorder, they have issues communicating or reading emotion and facial expressions, this could be a unique way to facilitate the conversation and to get the ball rolling on some couples work without the pressure or them refusing to do it because they're afraid of being in the same room with the person. So it is kind of a unique way to do it. We know some specific research into couples counseling in terms of barriers. Some of their treatment barriers, similar to individual, cost, childcare, and the stigma. We know gambling disorder and other addiction-related disorders carry a high amount of stigma, right? There's a lot of anxiety, a lot of shame that they're trying to work through. And we know that telemental health addresses those barriers across the board, and that's very supported in the literature. Even specifically for couples and family, there's a lot of research to support that this is an effective treatment setting. So looking at video, in terms of synchronous communication, video is the closest we have to face-to-face, right? So this is the easiest way to do it. If the couple are together and can be viewed on the screen at the same time, obviously you get that good information in terms of body language and nonverbals. That may not always be possible depending on if they're even in the same location. I'm working with some couples now that when the stay-at-home order hit, they were in two different places and they can't get to each other right now. So we're kind of doing it, one's in a hotel room, one's at home. That's okay. If you have a platform that can support that, that's great. If not, the ideal is to get them where they can be together and viewed at the screen at the same time. But you may have to coach them a little bit on how to use their technology, because if you think of the proximity, when I do sessions like this, you're seeing me on a very small screen. I'm a little closer to the camera, so you can see my face very well. But if I was in a group or doing a session with a couple, I would want them to be farther back because they might be a little uncomfortable if they have to squeeze in to both be on the screen. That might be awkward. So it's okay. I always tell my couples it's okay if you want to sit farther back. If you can put the laptop or the tablet or the phone somewhere at a distance, I'll tell you when I can see you both really well, and try to work it that way. I've had couples, if they have the technology, smart TVs are really great. They can cast their screen to their TV. So I'm actually on their TV, so they can sit farther back and they can still see me decently. So you have to get a little bit creative, but we want to make it as close to face as possible. So you're going to follow the same practices as you're doing for individual telemental health in terms of privacy, having that backup plan for technology. So making sure that they have a phone handy. So if the video cuts out or they can't get online that way, you can still call them on the phone. And making sure, with any telemental health practice, you're staying within your state lines. So, I got into a lot of detail about that in the first session, but if this is the first one you're seeing, yes, you do have to stay within the states with which you are licensed, unless you get an exception from that state's licensing board. It's kind of the rule of thumb. So you want to make sure that you are still staying within state lines. So if you're working with someone, you always want to check to see where they are, especially if you're used to a certain background and their background changes. Like, oh, a different room in your house? Are you out of town? What's going on? You want to make sure you're staying within your legal parameters. And you want to have the procedure in place just in case somebody leaves the session. So if you've had them in your office, I've had the situation where someone gets up, storms out of the room, slams the door. Well, they're not going to get very far because they drove together, for example. Or they're just waiting in the waiting room and I know where they are. If someone needs to leave the session, you want to have a procedure for that. So I always talk to my couples about that ahead of time. Hey, if it's getting heated, you need a break. It's okay. Just let me know. I want to make sure you're still safe. And if you want to step out, do you want us to continue talking? Do you want us to wait for you? You talk that stuff through, because I have found that people are a little more likely to get up or slam the laptop down or something like that in the heat of the moment, versus getting up and walking out of my office. I think would take a little more effort and maybe a little more, there's a little bit more of the social cueing that they're not comfortable with that. With technology, it's kind of easier to hang up, close the screen, kind of walk out in that respect. So I always kind of talk through that it's okay if you need a break, just let me know. Let's come up with rules as if it was a group on how we're going to handle that situation. So I find it happens a little bit more with my tele clients than with my face-to-face clients. So we know that, telemental health removes a lot of the logistical barriers, especially for working with families, because if there are adult children involved, for example, they may live far away, or you may be coordinating multiple work or school schedules, things like that. A lot of platforms will have a group function or even a way to drop a separate link. So it's a matter of whatever your platform you're using, kind of getting familiar with the tools. The platform that I use, I have a group function, so I can have up to 6 people, which includes me, so I can have 5 people. And it looks like kind of what we're used to with Zoom, where you have all the squares, the gallery view. But I also have a way to add someone to the session instantly. And I simply copy and email a link to somebody, and they click the link and they instantly join my session. So this is a great tool to use if you have someone who wants to include somebody in a session, but maybe, they don't want to, have them join the whole platform or go through those hurdles. My technology has a way to just kind of send a link. So these are just some things to look at if you're choosing platforms, or if you're already working with one, see if you have that feature, because it can be great if someone wants to bring someone in just for a single session, maybe to break some news, maybe to ask for help. We can still do that with telehealth. So I think in some ways it makes it a little bit easier. If you're thinking of incorporating this into your practice after we go back to face-to-face, this is a great blended approach where you can bring someone in through telehealth that maybe can't make it geographically. Again, we're a pretty big state. So if they want to work with their adult child or maybe a college-age family member who's at school, this is a great way to incorporate them into treatment. So it's just a matter of looking at what features you have. And Robbie, if there are questions I can answer as we go, please feel free to interrupt me. It's okay.
Okay, I'm sorry, Jessica. We've got a couple of people who raised their hands. I do have a question. So let's start with a question through the chat, if that's okay. And then I will, I'll try to get to the participants who are raising their hand. So Lynn just asked, could you say what platform you use, Jessica? She's asking platform.
I use a platform called We Counsel. Platforms, from what I've seen, kind of come in 2 varieties. One is where they kind of provide the referral stream, where you're a contracted provider to them. So like Teledoc, for example, is one that's getting a lot of press lately. You sign up, you contract with Teledoc, you get a 1099. They're bringing in the clients for you. We Counsel is a platform that basically provides a virtual office and tools, but I'm in control. I'm the provider. I bill through it. I have my notes through it. It's my own, my client's my referral stream. So it's a virtual office setup versus contracting for somebody else type setup. So Teledoc, it's similar to like an EAP model where they get a bunch of contracted therapists to provide EAP services. It's similar to that model versus We Counsel this is my private practice that I'm bringing online.
Yeah, I remember you covering that too. Lynn, if you go to, it was the first one, right? Jessica, you had a list on a slide on different platforms, which was very helpful. Martha asked, so if your client does live in your state, but is on vacation in another state, can you see them? I think is what she's asking via telemedicine. Okay, yeah.
Nope. The exception to that, obviously, if they're having an emergency, if they're in crisis, obviously that's unethical to leave them hanging, right? We want to address crises and emergencies. Routine appointments, you need to be licensed in that state, because the law is that counseling takes place on both ends, both when the counselor, the therapist, or in the person receiving the treatment. So you have to be licensed in both states. That's how it is for behavioral health. I know medicine, nursing, they may have some differences. Florida has a registered telemental health program you can look up that you don't have to be licensed in Florida to practice in Florida now. If you're in another state, you demonstrate competency in telemental health. So I've been certified in, they called it distance counseling before. They've grandfathered it to TMH. I've been certified since 2005. So I just sent them the proof of my training and proof that I was fully licensed in my own state. And now I can see clients in Florida. But so far, that's the only state to do that for behavioral health. So you have to be really careful. If they're on vacation, you want them to reschedule unless it is a crisis.
Okay, good. Yeah, good question. Way to hear that out, Martha. Get confirmation on that, and that's interesting because you would think, but yeah, thank you for letting us know that. That's good. I'm going to try to find, I think someone else.
Advocate for license portability with your board.
Yeah.
That's what we need. I know. I mean, I'm a counselor, so I am more in tune with our board and the American Counseling Association, but I know there's been emails going out like, tell your story, let's get some advocacy going in this time. Like, how is it affecting us? And I feel like I'm just a broken record. I'm like, please, licensure portability, telehealth, because we do have those situations where our clients travel and we want to provide consistent care. North Carolina borders several states, depending on where you are. Like, I'm 3 miles from South Carolina. I'm just south of Charlotte. So, you know, we have clients in South Carolina that now we're kind of stuck because they're not traveling to our offices. And we're just contacting the board and getting those exceptions. But it is a challenge. So I think one of the silver linings maybe to this crisis for our field is it might fuel, you know, some of the licensure reciprocity we've been going for, expansion of payers. So keep, you know, give that feedback to your licensing boards, to your representatives that, hey, you know, if we're looking at this long term, we really need to be able to work with a wider geographical scope.
Yeah, good point, Jessica, because I know just moving to Massachusetts, I just now got confirmation that my license, and this is but we know the frustrations, but the rules are put in place for a reason. But yeah, I think in this area and all areas, the way we do business, the way we deliver our services in the mental health field and beyond, some of it's going to change, I think, forever.
Yeah.
Right? So yeah, good point. I'm going to try to, so I know Nancy had raised her hand. Let me see if I can get. Okay. Hold on one second. For some reason, and I know you guys have heard me say this over the last several weeks, I have a problem unmuting folks, and I don't know if it's my computer or not. Oh, here we are. Let me try. I'm really going to be persistent. Nancy, if you don't mind, go ahead and chat me your question. I've been trying to unmute you now. And according to all the videos and training modules I'm watching on Zoom now, I think it's my computer. We got a couple more chats and then we'll get right back to it. Okay. Rico asks, is this just since the crisis that allows us to practice with telemental health in Florida, or is it regardless?
So the Floridian law, their telemental health law actually passed January 1st.
Okay.
So they've been thinking about putting that in place for a while, just because they don't have enough providers. Okay. I used to live in the state of Florida. I did not get licensed. We were only there a year and a half. And it was just the process of the licensure, you know, Robbie, as you're experiencing too with portability. Right. I started in Ohio and then Florida and then here. Getting those licenses transferred over, adding is very timely and costly. So I did not do it down there, but I heard they were moving towards it just because they just have such a need. It's such a huge state. So the Floridian telehealth law went into effect in January. So I think I was provider number 30, and I registered, I think, by the end of January.
Yeah, wonderful. Yeah, and I know you've told us on all 3 webinars about Florida, so there's opportunity there for us. Thank you, Nancy, for letting me know your note there. Marlene asked, I live in Virginia. I'm licensed in work in North Carolina. Can I do telemed from my home using my work computer?
Only if you are licensed in Virginia.
Okay.
If you're not licensed in the state in which you live, you may be able to contact your board and say, here are my credentials for North Carolina, here's my situation, see if they will allow a temporary exception. Some states, and you have to dig into, so I don't want to spend too much time on this, but basically you have to dig into the laws of that state, because everyone's a little bit different in terms of exceptions or temporary permissions. But some states have taken the approach that if you live in another state, you can work within our state for a limited number of hours or a limited number of cases. The rules are a little bit different. So I would suggest you contact the state board directly, say, hey, this is my situation. Can I have temporary privileges in the state? Or is there a way I can apply for licensure? Do you have reciprocity with my state? And try to get a license fast-tracked. But the short answer is no. You have to be licensed in both places.
Okay, and I've got one last question, and we'll get back to the material. What if a license isn't required? For Medicaid, some states use just master's level clinicians for reimbursement, and unlicensed graduates can do reimbursable counseling. She's saying, for instance, Massachusetts and I think Alaska. In this case, can states be crossed?
You're really getting into the legal weeds there. I'm not sure.
Yeah.
That would really come down to looking up the relevant boards and looking at the laws.
Yeah. And
that one I cannot answer for unlicensed.
No, that's all right. No, well,
No.
no, we got 91 people on there. There'll probably be, because is that even, no, that's a good question, Rosemary. Thank you. But I'm wondering if just the law without the telecounseling on that one, right? Does that make sense?
Yeah, I wonder if that's just a Medicaid. I was asking.
Yeah, Medicaid question.
Them, because right now Medicaid's kind of under, and I addressed this more, I think, in the second one. Forgive me if they're running together. I think in the second one that a lot of the payers are changing rules temporarily. Yeah. So Medicaid, Medicare, I know they have allowed exceptions now for those with counseling licenses to jump in. Yeah. Where before that's kind of been in the works, but it's been slow. Aetna might allow something different than Cigna. So if it's a situation where you're working with a specific payer source or population, go straight up and check with them, because there are a lot of temporary rules coming out. A lot of information is changing quickly. It may be allowed if you ask specifically and get the answer in writing.
Right. Yeah. Good answer. And that's what I would recommend too. If I kicked my practice here up and I had a Medicaid question, go to the source. But I think here how it's connected to telemental health and telecounseling, you would want to ask some specific questions to that. Does that change with this medium? But the Medicaid, yeah, that's
you're in the weeds now. I don't.
Yeah. Okay. Well, thank you, and I'll get out of your hair here.
So let's look at phone. Doing phone with couples and families, frankly, is really challenging. It is not my favorite thing because you have technology issues. You can, try to do a conference call. That seems to kind of be the best way to do it, because the line, it's clearer because you have direct connections. A lot of people will just sit here, have me on speaker and just literally pass a phone back and forth or try to lean in. If you can, on the provider side, if you have a headset with volume control, that will be very helpful, because what I'm finding, it really just becomes frustrating for all involved. I try to switch to video if we can. Sometimes I'm limited. Some of the EAPs I work with only allow video for certain plans, for example. We may only have the phone to work with, but it can get challenging because if someone, isn't leaning into the phone, or they relax, or they move, or if they're on Wi-Fi calling versus their cell calling, the volume becomes an issue and it can be hard to hear and understand. So ideally, I would suggest couple and family, try to get them on video. If phone is the only option, you may have to play around a little bit with, can we do a conference call option? Can we just pass a phone back and forth? And getting that headset with the volume control can really save your own sanity with that, because the volume levels tend to go in and out. So with groups, you may not have clients affected by gambling disorder in your immediate area, but now you can pull clients statewide. Some people are more comfortable with this because there's less of a chance of them running into each other socially. So if I have, a client in Charlotte, one in Raleigh, one in, Greenville, one in Asheville, there's a really low chance they're going to run into each other at the grocery store, right? Or, the kids' soccer game kind of thing. So online groups can really appeal to those that are fighting that stigma, or maybe are resistant to join a group. You can kind of, explore this option if you have enough clients, because it can really be effective for those who isolate themselves, either geographically they're isolated, or ego, if they really don't want to interact with others. But again, that we're staying in your state. So working with privacy and confidentiality, just like face-to-face groups have no, legal obligation to protect each other's information, right? We hope they would do that. Maybe morally they would do that. But again, as far as a legal standpoint, they're not obligated. So we have increased risk with online groups as compared to face-to-face. The group, they may not be alone. The person, one of your members may not really be alone. Someone could be sitting next to them and you can't see on their video. Their Wi-Fi could be compromised. Members can record and take screenshots. We see these composite pictures of Zoom sessions where we can see everybody. Someone could be taking a screenshot. They could be communicating simultaneously. So they could be in the session with you in the video, but they could be on their keyboard or, on their phone in their lap texting somebody. So again, it's discussing risks, setting those group rules. If you're not familiar yet with the Tele Behavioral Health Institute, I'll have their information a little bit later. If nothing else, sign up for their newsletters. They have a lot of great information because they focus on TMH across all diagnoses. So they put out a lot of information about best practices and things to consider to protect everyone's safety. They just put out a really detailed, like 2 or 3 page document about things to consider with running groups. And this slide just touches on it, but things like using landlines instead of Wi-Fi, and different ways to protect confidentiality and privacy. So if you have a group that was already running and you already have that trust built up, it might be a bit easier to move them online. But starting one, it's a little more challenging. There's a little more legwork involved because you have to go over some of these other risks. Most of the time, people, we're talking about groups, they don't even think about doing this stuff. They're like, oh, I didn't think I could screenshot. Like, oh, I'm not giving you ideas. But these are just risks we have to consider. These are things that could happen. So other ways you can protect privacy and confidentiality: wearing headphones and earbuds. So when I am doing clinical work, I have a headset on at all times. I don't doing things like this because I think it's a little distracting if you're watching my face. And in situations where I may have people that maybe need to rely on lip reading, I don't like having something in my face when I present. But typically, clinically, I am on a headset. So it just prevents it from being heard, outside of the person's setting. Using aliases or nicknames, if you're comfortable with this, having clients give themselves nicknames so they're not giving their real first and last name to other group members. It's kind of going back to that anonymous setting. Plain background, so talking through people, being in a plain setting, blank wall behind them. If they can't do that, if they don't have anywhere in their house that's kind of neutral, some platforms have those virtual backgrounds, which can be kind of fun if the bandwidth supports it. It doesn't, slow everything down. Wearing disguises and masks that don't interfere with speech. That's another way to protect group privacy. And understand, some people will say, well, I'll just, close my video. If the video feature is turned off, then it's considered phone counseling. So just be aware from a reimbursement standpoint, now that, we have the video technology, like platforms like Zoom and Skype and things like that, where you can go voice only. It's great because it saves bandwidth. It prevents some tech issues. But at that point, legally, it can be considered phone counseling. So just something to keep in mind. And I think it would also change the dynamic a little bit if, one person's screen was blacked out and not others. It could be a little odd for the group dynamic. So that was just kind of a quick overview in terms of groups. So switching, I know, to the big topic, this is the one I'm getting the most questions on between between these webinar sessions has been how to handle suicide and emergencies. So we're just going to dive right in. We know that, this really could be its own topic because we do have a higher rate of suicidality in those with gambling disorder than other diagnoses. Because they're not physically making themselves ill with a substance, we know they're coming to treatment much later in terms of the progression of the disease psychologically. So we know there's a lot of other emotion regulation issues, maybe some financial issues. So we know there's a much higher rate of suicidality. So we really need to be mindful of this if treating them through telehealth. We've seen higher correlations of suicidality with having female gender, gambling severity, other co-occurring mental health issues, financial problems, especially if the financial problems affect the family, and other conflicts that are directly related to gambling. So we know all of those kind of exacerbate the potential for suicidality. So we need to know how to handle it. So with suicide, it's typically not appropriate for telehealth to be working with active suicidality, right? This is kind of obvious. We have safety issues. I've contract with various EAP firms that provide telehealth, and every once in a while I get a referral that client called actively suicidal, has a pistol. I'm like, what are you doing? I will drop everything, call that case manager and say, no. I'm not just going to talk to him in 3 days at 8 o'clock. Like, we need to go through some safety procedures. We don't want to see this go to telehealth if the suicidality is the presenting issue. So, but we do have to be prepared to handle it, because just because it's not the primary concern doesn't mean we're not going to see it pop up in the course of treatment for gambling disorder or anything else. So what I see, we know about the gambling hotline or the suicide hotline. Hotlines were really the start of telehealth really back in the 40s. We were seeing hotlines come up. So many people start with that, or they may be comfortable with that because maybe they've called a suicide or gambling hotline a few times and they want to stay on the phone. That's their comfort zone. So you may be in a situation where this is the only option for them, and their opinion is doing it through telehealth. So you want to develop that safety plan just as you would for a face-to-face client, but it's going to look a little different because you're not with them. And you also want to go over your policies for contact between sessions. So if you were previously face-to-face, looking over, what were your policies, what's in your informed consent in terms of contacting between sessions for crises. Do you take those crisis calls? Do you refer those crisis calls somewhere else? Think about how you're going to handle that. And if you do allow it, I have a few clients that maybe they're going through something temporarily. I will allow clinical contact between sessions. I use an encrypted texting app. The one I use is called Signal, Signal. There are several of them out there, but that's the one that I use with my clients. I download it, they download it, and we can text through Signal, and it's encrypted. If you're going beyond canceling, changing appointments, I would definitely move towards an encrypted app. So discussing that contact, if you feel someone needs a little bit more support, making sure they have those resources between sessions. So how to handle these emergencies, right? They can happen just as easily telehealth face-to-face, and our responsibilities remain the same. So we have to go a bit beyond duty to warn, right? Harm to self, others, abuse, we all have that. But what about environmental emergencies? These are things we don't consider as much in our face-to-face offices. But what if wherever they are, a house fire breaks out, or they're in a situation where there's extreme weather, any kind of other disaster, flooding, other safety risks? What if you're on the phone and there's a home invasion and assault? We see this a lot with IPV situations. I had a situation where I had a client on the phone, and her estranged partner, who she had a restraining order, showed up in the middle of the session, just showed up at the home. And we had to deal with that, and I had to help her through that process and getting safe. And I'll go step by step in just a minute. So it really does go beyond duty to warn, because you're no longer in control of the environment. You're in two different settings. What if you have a situation? What if you have an emergency? How would you handle that with your client? So these are some extra things we have to think about, because now we have two settings and you don't have control over theirs at all. So the safety piece and the handling emergencies really can be addressed at every single stage. So at intake, you want to get, a lot of the information you're probably already collecting, but a secondary phone number than the one you'll be talking on if possible. An emergency contact, I like to, kind of take it with the angle like, hey, is there someone else who's going to be at home? Someone close? I'm looking for physical proximity. I don't want an emergency contact that lives an hour away. I want to know who's around them that could get to them if needed. Any other relevant health information, any other medication, chronic condition, etc. If you don't ask this information now, which most of us I think do because the brain and the body are connected, but having that information on hand in case you have to call 911 can really be helpful. Knowing their nearest emergency facility that's in their area. And if you're not familiar with their area, if they're not in your town, do your own research and take notes on this. You want to have resources noted in their file in case you need to get to it quickly. So this could be anything from local crisis centers, food banks, any county resources, any hotlines that serve their area. You need to do a little bit of extra legwork and get this for each client, because if they need a resource and they're, I'm in Union County, I may not know what everything that's available in Anson County. So I'm going to have kind of a short list in my notes for that client with all their demographic information. What else is in their area? What is their crisis hotline? Do they have a county base? Is it town based? Because if there's an emergency, I want to know who to contact, and I want to know what resources I can give my client without having to stop and search for it and get back to them. So that's a little bit of a difference with telehealth, because we can't all know every county in the state, right? So if you're working with people who are local to you, it's less of an issue. So with the informed consent stage, just like face-to-face, you want to document emergency procedures and discuss these. Hey, so if we get disconnected, I'm going to call back. If there's an emergency and you hang up on me, understand I'm still under duty to warn. I'm still going to persist in contact and try to get you help. So you talk this through before it happens. You can work it in with duty to warn or with the pros and cons of telemental health. So if I have a client that is already telehealth, I work it in with duty to warn. But if it's someone who's face-to-face or someone who's maybe considering, I work it in with the pros and cons. Like, these are some things we have to think through. This is what you can expect. So this is another, step in the process. We are proactively discussing emergencies. So calling for help, this is the big one. Excuse me. So calling for help, this is the big step I get a lot of questions about. This could include reaching out to another provider, to their emergency contact, or to 911. So when you're calling for help, always have a secondary line of communication available for you. So when I am working, I have two cell phones. So I have my very boring, cleaned off smartphone that's very plain. My work phone has no other apps, nothing else that can be recording or reporting anything. I'm on this phone with the client. If I have an emergency, I have my personal phone handy. It is typically off, or it is, everything is turned down, and the smart record option, the option that uses like Google Assistant, Siri, have that turned off so it's not accidentally recording my conversations. I have that next to me as well. So if you're in a situation where you need to call for help, you want to keep the client on the line. So if you're on the phone, I'm on my headset with this phone with the client, but in the other ear, I have my headset off of one ear, I'm on this phone calling for help. If it's video, it's a little bit easier because then they can see you calling, and you can, you have two lines of communication that way. You want to keep the person on the line of the screen while you're making the call, and do not disconnect until that handoff is completed. This is very, very important. And if they hang up on you, you want to keep calling them back until you know that someone else is physically there to take care of them. You don't want to disconnect with them until the handoff is done. And then document, right? If you've discussed recording with your clients, I know when I was still provisionally licensed, I would have to record sessions for supervision. So I discuss with my clients, if I have an emergency, I may record the call because I want to make sure we have all the information we need, that kind of thing. Some are comfortable with it, some aren't. Just, as when you're recording in supervision, but I discuss it ahead of time to say, hey, heads up, if this comes up, I might suddenly hit that record feature. My video portal has a record option. I might suddenly hit record just so I can get that information that a first responder might need. And then you document, in their notes when everything's calmed down, you document in your clinical notes from the start of the event to handoff and your follow-up if possible. So you want to make sure you've got everything documented to kind of cover yourself. And then how to call 911. Understand that, emergency services really vary by jurisdiction. We don't like to think about this, but every few months we see something on the news about issues with our 911 service. And, the technology that they have and the resources they may have really can vary. So you may call 911 in your area. You might be going to your town. You might be going to a county. You don't really know. So just understand it's going to be different where you are versus where your client is. So when you call 911, you're actually calling your local service, not theirs. So you identify yourself as a mental health professional. You state where you're reporting the emergency. They could put you on hold while they're trying to connect to that jurisdiction. Believe it or not, some places you're actually on hold waiting for several minutes. They may start asking you the questions, or they may have a service where they're asking you the info and they're relaying electronically to that jurisdiction. Again, everyone's a little different. So don't let that distract you or startle you. If they say, okay, I need to put you on hold, you're like, wait a second, it's 911. They may need that minute to contact the other jurisdiction, or they may just dive into it and then they're typing and you're giving them all the information. So you're going to describe the client, age, gender, any significant medical details that you know of, what the situation or the threat is, give the address if they haven't already asked for it, and explain again that you're a telehealth provider and how you're communicating with the client, right? So it looks like a lot of steps, but it literally sounds like if I take the instance where I had the client that was on the phone and the husband came into the house, 911, state your emergency. Hi, I'm a professional counselor. I'm calling to report an emergency in Mecklenburg County. She put me on hold. She's like, let me start getting info because I know it's going to take a minute. And I was able to tell her, I have this age, female, this is her home address. She has a restraining order on her husband who just pulled up in the driveway. And as I'm doing this, I'm also listening to the client. And then she starts telling me, I'm going to go out the back door. I'm going to go to this person's house. And I say, okay, client has informed me. She's leaving the premises through the back door, going to this address. And we just kept that going until she ended up going to a neighbor's house a few doors down, going in through the back doors. The husband never saw her leave the house. And I stayed on the phone with her until the police officer was on the scene, took the phone from the client, talked to me. I gave them report again. And then I asked for their badge number just to make sure it was, covering my bases with my documentation, asked for their name, their badge number, and their jurisdiction, and made a note of all that. And then, advised the client, hey, send me a text when you want to talk again. Like, let's follow up. Let's circle back whenever you're ready. So it looks like a lot of information. It goes very quickly. Some 911 services will just start prompting you. They'll just start asking you questions. But if they just say 911, what's your emergency? This is the information that they're going to need to know. So I mentioned earlier about the Telebehavioral Health Institute. This slide has been in all three presentations. If you've seen the DCC credential, through Ready Minds, it was updated in 2018 to board certified telemental health provider, which is great because it's more inclusive of other disciplines that are doing this, not just counseling. The CCE is still holding that credential. They have a different, they've outsourced the training to the Southside Telehealth Training Academy. And then the Telebehavioral Health Institute is run by Dr. Marlene Mayhew. They have their own certificate programs. So this is one of these things, again, this is a certificate or a credential. We're not talking about state regulations. There's different ways to go about this, but these are the two most, in my opinion, well-established, reputable, evidence-based paths to certification in the area of telemental health. And if nothing else, if this isn't a path you want to go down long-term, maybe you're not ready for the certificate or credentialing phase yet, go to TBHI and just look through their website and all of their resources. They offer consultations. They have a great newsletter that covers the entire field. It's not just behavioral health. They'll cover some telemedicine information there as well. So if you're working in a setting that is combined medical and behavioral health, it's a great resource. So I always want people to have that information. So with that, what questions do you have? I know I'm seeing some chat, some hand raising. Let's go. What you got?
Yeah, we've got a few here. Some of them are just comments. One asked about a sample. Got to combine two words. Sample safety plan outline. I think you went over that about 3 slides ago, somewhat. I don't know how.
Well, I mentioned safety planning because that's going to be individual for each client, right? So you're taking your, let me see, your typical safety plan that you would have for a client that maybe through this slide, that you typically have for a client, if you have a crisis outside of hours, this is what you do. You're just taking it up a notch, basically, to modify it to a telehealth setting. So you're still covering the same bases, but if you have a client that's not in your area, you just have to basically ask them, like, hey, where's your nearest emergency facility? Right. I ask them for 2 reasons. 1, I want to know. 2, I want to know where they're comfortable going. And 3, it gives me an idea if they've had experience with it before. It's like, oh, I think there's an ER a couple hours away, or a couple miles away. Or the other extreme is, oh no, when I have a crisis, I go to this agency and they're 24 hours. Like, gives me some insight as to their prior experiences. So I ask them, and then when I get that intake form back, we have that conversation, gives me an idea if they've experienced it before a little bit. But then I will also do my own research in case I have to refer them.
Yeah, good answer. I remember when I first started working the lines at Morneau Chappelle or BDA at the time, and it's really, you think you're prepared. I did a talk a couple weeks ago for Illinois on suicide and problem gambling, and I thought I was prepared because I came to this company coming out of doing crisis work in an emergency room setting, and frankly, I thought, yes. Boy, I learned real quickly because it's a different world. We all know that on the phone. Now, I had an organization or company behind me. In other words, the first caller that I had that I faced some really, I think it was anyways, it was some strong ideation, but we had managers who would break in, chat, and call the emergency the authorities in whatever state they were calling from. So what I would say is be prepared if you're on your own and you're running a practice and you're doing this like Jessica does, what that safety plan and what steps you would take in order to do it if you were on your own. I've never experienced that. Again, I did it over the line. I have worked with suicide or callers who were suffering from suicide ideation, but never as a standalone practice. So you got to be prepared, right? So Nancy comments, your comments about emergency procedures are important. Remember, the client might be at home, trips and falls in the kitchen while on a call with you. This is medical emergencies as well. You brought up a good point, Jessica. I like that. During COVID-19, it's going to be different because it's all in the family right now. Maybe on the screen. Yeah, right?
Yep.
So things I guess there's more opportunity for interruptions, either if they're safety hazards or not. So let me go to the Q&A. Let's see.
Seeing a lot of medical stuff too, because people are a little afraid to go into an ER urgent care right now. Yeah. Or maybe their local one is overwhelmed. They may not have access to their doctors right now. If you think about, if you have a client on the phone, what does a panic attack look like? Looks
Yeah.
like a cardiac event. And guess what? It sounds like it too. I've had to call a couple times because we weren't quite sure if that was panic or if that was a heart attack. So
Yeah.
this stuff does happen.
Yeah, if you don't, if you've never been or seen a panic attack actually happen before your eyes, I know as a new clinician right out of grad school, one of my first calls was I made an on-site call and she had a panic attack. I sent her to the hospital and got in trouble. Yes, just
Oh,
knowing the panic attack to have her, cope with it at the time and didn't get in trouble, but it was, yeah, that's how you learn. So BK asks, what is F2F, which is face to
oh,
face?
face to face.
Yeah, right. Yep.
Sorry, little
Good
shortcut.
question. That's
We love those in mental health, right? We love all these acronyms.
all the acronyms.
You'll see in the distance, the telehealth language, F2F is face to face.
Yeah.
So yeah, sorry.
No, it's all right. I still learn new acronyms almost, it seems like, every week in this business. Okay. Yes, F2F is face to face. Let's see here. Okay. Do you typically check client location in each contact? How would you handle a situation where the client, and you talked a little bit about this, I think, last week, in Walmart parking lot, on Zoom, or on smartphone?
So for phone at the beginning of the session, I'll say, hey, is this still a good time to talk? You in a good spot? Just kind of casually. And I kind of, ask that they confirm that with me, but I do it in a very conversational way. So, hey, is this still a good time? I turn my microphone up and listen for clues that maybe they're outside or in the car. The car thing I also go over, at the outset, like we don't do sessions in the car, period. If you go somewhere and park, because that's the only place you have privacy right now is that Walmart parking lot, fine, but we don't want to be actively driving while we are talking. For video, you'll see their background. And sometimes I'll be like, oh, wait, that's somewhere new. Hey, where are you? Like, oh, that's kind of cool. Like, swing it around. Let me see. And have them like literally kind of move their screen around a little bit. Or, I had a situation where a young man where the background was different. And I asked, I'm like, oh, so you're not home. Like, what, are you just in a different room? And he's like, well, no, I saw these degrees on the wall behind his head and he was in college. I was like, oh, where are you? And then he turned bright red. It was adorable. He had to admit to me that the degrees on the wall belonged to his mother and she was a social worker. So had to work through some of that. Oh, you're hearing everything your mother's been telling you from years from now a counselor. But it gave me a clue that, oh, he did have the support system. He went to his mom's house. So yeah, I do try to verify location with every interaction. Some providers also will will try to verify identity. So on the video, obviously, it's just like face-to-face, you recognize the person. Sometimes on the phone, they'll ask for a code word or ask, hey, do you remember what we talked about last time, to try to make sure they're talking to the same person.
Very good. Yeah, just kind of fitting it into casual conversation. I like that.
Yeah, that's more my style, but everyone's different.
Right. Yeah. I'm kind of the same way, even face to face. So they don't feel too awkward. Okay. Bethany asked, as being a certified telehealth provider, this might be more of a session one, quite a good question. Mm-hmm. Does being a certified telehealth provider just allow you to do telehealth anytime, even though there isn't a pandemic? Do I need to do anything to do telehealth during this? Does malpractice insurance automatically cover telehealth?
It goes back to, staying in the bounds of competence. So with the emergency, go back and look at the first presentation from a couple weeks ago, because I included, I think it was towards the end, the actual language that they're saying in terms of loosening up the reinforcement of HIPAA and some of the rules that are changing. With anything else, I wouldn't recommend doing it without some kind of basic training and comfort level. Again, it just goes back to ethics. So you don't have to have the certification to do it right now, because it's the only option. Like, ethically, we have to serve our clients. Once this is over, you might see some of the payers go back to changing their rules. So I am certified in telehealth. My practice is 100% telehealth for the past 4 years. So I have no problem. I'm paid at the same reimbursement rate as if I had a face-to-face office for all the insurance companies with which I'm paneled. Now, I don't have anyone Medicaid, Medicare. I can't speak to that. But in terms of private insurance and EAPs, I'm paid at the same rate. But I'm licensed, I'm certified in telehealth. So it really depends on the individual policies. But as a provider, it goes back to the ethics and staying in the bounds of our competence. Everyone's jumping into it now. It goes beyond the scope of the crisis. There's so much more to it, as you can see if you go through the presentations, than how we're kind of making it work right now. I think a lot of providers are going to find it's a great option to do a hybrid practice. So having face-to-face, but if you have a client maybe who, doesn't want to travel or is a little bit out of, range, or maybe they can't make it that day because they have a childcare issue, something like that, you can fall back on it. But I would still recommend getting trained, getting certified, because honestly, as you know, with any healthcare professional, at the end of the day, there's that liability piece, right?
Right. Yeah. Yeah.
My liability insurance I do have a telehealth rider on it. It wasn't that much. I just have an extra benefit for telehealth related stuff, because if we were to go deeper, and this is beyond the scope of what we're doing kind of in these 3 weeks, but if we go deeper, then you're looking at things like HIPAA compliance, encryption, data breaches, things like that. So this is kind of the tip of the iceberg. Again, a lot of exceptions to the rules have been made in terms of, enforcing or going after providers if there is a confidentiality breach because of technology. Now, I don't think that's going to last. I think once this crisis is over, we're going to go back to the way things were, but with maybe some increased knowledge and interest in this section of the field.
Okay, yeah, very good. Yeah, thank you for that answer. Yeah, it's time to change it. I think even once we get through this pandemic, I think it's going to change the way we deliver our services for good. Not a complete change, but I think a lot of people are going to remain, they're going to feel comfortable with this because their hand was forced at it. And they're like, hey, I kind of like this, right?
Mm-hmm.
Some of our clients, I would imagine, anyways, my two bits, but thank you very much. And by the way, guys, we're past the hour, so we appreciate everybody being on. We got a couple other questions, Jessica, if you don't mind, if you've got a couple.
I can hang. I'm good.
Okay, if not, let me know. But yeah, we've got a couple other questions, so let's go to the Q&A here. A couple people raised their hand. We know that I'm struggling with that, but we can try again. Okay, Valerie asked, how do you handle new client intakes for signatures to documents? Is there a location where this info can be addressed? I guess via the platform you're using, right?
Yeah, so for intake for my platform for We Counsel, I do have DocuSign. So I send them the intake through, it's a secure portal. I send it through the portal. They can sign it and get it back to me. And this is, pretty widely accepted. I do have, if I have clients through other EAPs, like if it's a Magellan, a Cigna, those other EAPs where they require the signature, I physically mail it out and get it back. But then I have situations like, with Morneau Chappelle, I've been an EAP provider for them for quite some time. No one sends it back. I don't even have their home address. Sometimes I get an email. And honestly, those are such brief encounters. I go through it verbally and document it verbally. But if you need that hard signature on, the informed consent, because you're doing more clinical work than an EAP scope, then using mail, using fax if you can, or finding a program that will allow you to do the DocuSign. I've even had clients kind of in a pinch, I'll email it to them. And if they can't get it to work, or maybe we're not using the We Counsel portal, they'll sign it, take a picture on their phone and send it back, and I upload it.
Cool.
Technically, It's not the most secure option because, it's not through a HIPAA compliant portal, but if it's what we got, that's what we got. I just document why we had to do it that way.
Yeah, well, and I understand. Yeah, sometimes we got to do what we got to do. So,
Be creative.
yes. And then, and thank you, everybody. They're sending great. I'm seeing questions in chats, but mostly they're thanking you. The last question is, how would you handle? This is a good one. How would you handle a suicide case if the person, took out like a weapon, right? Like a gun on video. Have you heard any cases like that?
Yes. So if you have them on video, and it's turning sideways and it's happening, you pick up that phone, you call 911, and you give them all the information you can. If you have a video portal that can record, start recording. That would be where I would cross the line without saying, hey, I'm going to record you now. No, I'm just going to start recording. Because, anytime you have a weapon involved, it adds a layer, right? So it hasn't happened to me personally. I've had it on the phone, not on video, in terms of having a weapon in proximity, but it's just calling 911 while you have that person on and then telling them, what's going on, what you're seeing. They will get someone there pretty quickly. I've had pretty good experience calling for help. I have talked with other providers who have had a client complete on a video, and it's horrible. It's traumatic.
Yeah, and maybe it would be more of I guess, a better chance of happening because they're in their home. It's long distance, so right, they're not in your office. So I'd imagine the state.
It's still rare because suicidality, and we know suicide tends to be impulsive, tends to happen in isolation.
Yeah.
So it is pretty rare. The colleague that had that experience, the client had, it wasn't addiction related. It was actual years of dealing with psychoses and other mental health issues. And it really was just very high risk. And the only reason that it was telehealth was because they refused to leave their house. So they said, okay, they'd been seeing them face to face. And so he was just trying to reach out, and he kind of had a feeling that if he didn't talk to him, he wouldn't see him again. So he tried, and that's what happened. The client had kind of made up their mind to complete. So it is really rare. I've had situations, I usually, with the suicidality, the active suicidality and the weapon, I'm actually seeing it more in intake and the intervening, like, hey, it's usually coming through the EAPs because people, EAP, they're free sessions. So they're not reaching out to me through private pay or through their insurance. They're reaching out to their EAP, and I'm seeing more of the suicidality through the EAP referrals.
Yeah.
And then trying to educate the call centers, the EAPs, like, whoa, no, this is not a telehealth appropriate. And I know that we can't do face-to-face, so everyone's doing telehealth, but you need to call for a safe and well check in their jurisdiction right now.
Yeah, no, that's a good point too. That puts it in perspective. Overall, it's rare, but it does happen. And you're right. In this format, when you're doing private practice work for these sessions, it's very, very, it's somewhat rare. Like with EAP, which I have experience in it as well. We also work an addictions line for another state where I'm telling you, it seemed like every other call. Because think about a helpline. When folks call a helpline, they're at a point a lot of the time where they're in some pain and they're in that moment. So that too, but but it's very rare, and especially with, I would imagine, like you said, backing what you said was, in these hourly sessions, it's not going to happen as often.
Correct.
But we got to be prepared for it.
Yeah,
So,
I mean, telehealth is a way to break through that isolation.
Yeah, because it is.
Rare.
It's something that usually happens in isolation, right?
Yeah, because they can reach me. I mean, I've had clients, text me that we have the secure texting app. I need to talk right now. I'm in that dark place. It's like, okay, shove my kids to my husband, get the dog out, and I'm calling. And they know in those moments too, I'm not in the ideal location. They might hear my dog barking or my kids yelling in the background. But getting to them much faster than if they had to go to my office or go to a crisis center. I always keep my clinical phone on me. I'm a one-person, practice. I'm totally solo practice. So my phone's on me all the time, 24/7 anyway, my work phone. So it's a way to kind of maybe alleviate some of that because you can get to them quickly and meet them where they are.
Yeah. Well, very good, Jessica. And we appreciate not only today, but the prior too. It's been great having you on board, and we look forward to, we'll call you for some future one, a future.
My pleasure.
Sure. Yeah. So I know I personally have learned a whole lot, and I'm going to have to go back to some of the other sessions because, like I said, it's very rich and it's very relevant. I think a lot of people are going to take advantage of the opportunity that COVID-19 has taken enough from us. I think perhaps finding opportunities as far as business goes is fine as long as we're helping people, is my take, right? So this has been very helpful. Thank you very much, and we'll definitely look forward to, I'm sure we'll work again together in the future.
Absolutely. My pleasure. Thank you, everyone.
Everybody have a nice, happy, safe day. And we'll see you next Thursday, May 7th, where Dr. David Ledgerwood will be speaking on co-occurring disorders and problem gambling. And also remember to go to the UNC Behavioral Health Springboard website, register, get the slides, this one as well, and hear the recorded versions of all past webinars. Have a great day, guys. Thank you, Jessica. See ya. All right.